to surgical resection for primary lung cancer, and audit of compliance with the BTS guidelines. The BTS published its revised 2010 guidelines on the radical management of patients with primary lung cancer in 2010. Pulmonary function testing was proposed as a crucial predictor of operator morbidity and mortality. In view of recent evidence, which reveals poor correlation between the TLCO and the FEV1, the BTS recommended that TLCO should be performed in all the patients regardless of their spirometric values. Now, the anecdotal experience suggests that this advice is not followed in all the cases, so we decided to perform an audit in our unit to assess our practice. Using our unit database, we identified 122 patients who have undergone major lung resections over a 3-month period. We then reviewed patient case notes and the respiratory lab database to establish whether these patients had undergone PFTs prior to their surgery, and we particularly investigated if these patients had the TLCO calculated along with the FEV1. We also noted whether these lung functions were performed at the referral center prior to surgery, at the time of referral, or in our unit at the time of admission. Some form of pulmonary function testing was performed for 97 of the 122 patients, out of which only 70 patients had their TLCO calculated, and this is a group of the patients who was referred. Everyone who had PFTs at Jubilee had their full set of PFTs. Now, this obviously was not satisfactory, as despite the national guidelines, only 58% of the lung dissections fulfill the full recommendations. The actions: we presented this audit in the National Scottish Thoracic Society meeting, where respiratory physicians from all the referring units were in attendance. We also discussed these findings in the regional MDTs and devised a standard referral performer to highlight this issue. The pre-assessment team was also informed, and we displayed the posters in the relevant departments. After 6 months of transition period, we then re-audited. The second cycle of the audit was carried out on a sample of 50 patients. And as you can see, pulmonary function tests were performed for 48 of the 50 patients out of the referred patients at the base hospital at the time of referral, and out of which 42, which is 84% of these patients, had their carbon monoxide transfer factor calculated along with the spirometry. So, although not 100%, but this is a marked improvement, and obviously the future re-audit is essential to make sure improved compliance. So basically this is a closed loop audit where a problem was identified, highlighted, and change in practice and further improvement in practice was noted by the simple way. Thank you.
Question from Richard.
Thank you, that was fine. Very nice audit. The patients that didn't get the KCO patients, they were all peripheral hospitals, weren't they? It was obviously easy to get the thing done in your centres in Liverpool. When I see a patient in a peripheral clinic, I sort of feel lucky to get the spirometry. Certainly lucky to get the notes and the CT scan. It's a different world out there, isn't it? And I don't consciously not get the DLCO. But there are some patients, the ones who aren't breathless, who've got a normal CT scan without emphysema, they're not breathless, all those sort of things, I don't worry as much. Do you think that's why some of these patients didn't get DLCOs, or the surgeons just, they just didn't get it for whatever reason, or do the surgeons actually not bother about it in some patients? What do you think? Well,
there were actually interesting findings when we presented this audit in the Scottish Thoracic Society meeting. one element we identified was a little bit of lack of awareness. People didn't actually really know of this, and I think that's why they were doing the spirometry but not the TLC, because they thought maybe it's not important. The other thing, not all the referring centres to us have this facility, so that was the other thing we identified.
Thank you. I think I'll agree with Richard's comments. The TLCO was written down as a recommendation because, as you said, we decided, the evidence literature suggested that the FEV1 and the TLCO are two independent measures. One is airflow resistance and one is actually transfer of oxygen. The fact that some patients or proportion do not get TLCO and proceed to surgery suggests that the surgeons may not be exactly what you said, thinking that this is important. Because if you follow the BTS guidelines down, they say that if your post-operative TLCO is less than 40, then you are at moderate to high risk of post-operative shortness of breath. So I guess it's a measure of, the problem is not in the process or the loop, but the problem, as Richard pointed out, lies with the consenting surgeon, whether or not he or she feels that this is an important measure. Because if he or she feels that this is an important and valid independent measure, then surely he or she would not let the patient go into the operation without formally consenting for risk of shortness of breath.
Yeah, no, I fully agree with you. These two measures, they are completely independent, and you can measure different aspects. Again, it goes to the operating surgeon.
Okay, any other questions?
Thank you.